I'm going to talk today about decision making in young arthritic knee, and this is what has been redefined the knee surgeries. So Jacob Jacobi, way back in 2004, had described the biological solution for all the mechanical problem of the knee joint, and till now we had a mechanical solution to biological problem of the knee joint. And one has to suggest, if you see this data, what exactly is a young arthritic knee is a confronted tissue of multiple disease like meniscus, ligaments, and the limited treatment options which are available. And that makes the surgeon's life more vulnerable how to address this issue. So issue of young arthritic knee has been designed in few fashion, especially the cartilage, meniscus, and alignment. And if you see in toto, the alignment has to be normal for your cartilage to be absolutely functional, the meniscus to be functioning up to the mark, and the most important is the alignment. With keeping all this in mind, ISRJR has designed certain treatment options. And the commonest options which we follow in our clinical life, if symptom relief, that is the medical management of osteoarthritis. Regenerative medical medicine is the one which is picking up, but it's not up to the mark. Salvage procedure in the form of high tibial osteotomy in partially replacement and replacements, which we are going to discuss in today's life. So in short, joint preservation has to be tethered upon. The ideal patient for osteotomy and unicompare, you can't compare apples with oranges because these are two completely different stories. If you see the young arthritic knee, the management protocol, if you have to assess patient less than 65 years, then you have to see for the associated ligament injury. If it is associated with change in malalignment, the sagittal and coronal alignment, the best way to address that issue is by high tibial osteotomy. If it is without ligament instability and it's because of the cartilage damage and the intra-articular cartilage deformity, then best is by unicompartmental osteotomy replacement. So if you see the intromedial, the pathophysiology of the disease, you'll realize in the approach to the knee, arthritic knee joint, one has to understand the damage to the articular cartilage in weight-bearing axis, especially damage to the articular cartilage in the tibial side and the femoral side in tibiofemoral articulation in extension. And with this will lead to the laxity of the ligament if it is associated with great loss of the cartilage and associated with complete ACL damage. So with this in mind, one has to understand that if it is ACL along with the MCL laxity, this young arthritic knee, the best option is not the UKR but the high tibial osteotomy. So addressing the issue, one has to understand that alignment is the key. The first in thorn is the alignment, and unless you correct the alignment, you are not going to get the optimum result. See, metaphyseal varus of the knee joint can be addressed by high tibial osteotomy. And why this is important? Because the outcome measures of high tibial osteotomy after this correction of metaphyseal varus are far, far better than your HTOs, as it has seen. The intra-articular varus, which is more corrected by uni, can give you a better outcome. And this has been presented by many researchers as they get almost 95% of good, better outcome, especially in a specialized center, even with the non-robotic surgeries. So the ideal indications for high tibial osteotomy in my clinical practice is 50 to 58, up to 60 years, less than more than 5 degree varus, full range of motion, medial meniscus cartilage is damaged on MRI and there is localized compartment pain. In those situations, I can get better outcome even with good HTO. The survivorship of HTO is very well known, and there are n number of studies to show that comparison long-term survival for this open wedge osteotomy versus knee arthroplasty, especially in younger population, is far, far better towards the high tibial osteotomy. So is there any indications for uni? Yes, surely the uni is more indicated when you have completely single compartment involvement, correctable deformity, intra-articular deformity, localized pain, and no osteonecrosis. So it's very important to have this criteria in mind so as to get better outcome. So the treatment of medial compartmental osteoarthritis has been surveyed, and in American Association, they found out that younger the population, the HTO goes in more favor, because return to sports and activity is far, far better with high tibial osteotomy than with UKR. However, the UKR gives a better gait pattern as compared to the HTO when you compare, because UKR maintains the natural varus which cannot be maintained in high tibial osteotomy. So open wedge high tibial osteotomy versus unicompartmental knee replacement has been studied by many researchers, and they found out that the gait pattern is much well preserved in the UKR cases than with HTO because of patellofemoral and valgus malalignment. So in short, the decision making in HTO versus uni, the HTO you have to consider for the age, the severity of deformity, activity level, return to sports, survivorship, range of motion, and subsequent conversion to total knee replacement. While you consider the uni, the most important criteria is the less correction and more of pain control, which can be achieved by uni. I think we have to have a very open focus onto this decision making in young arthritic knee. Thank you.